So obviously I'm here from Children's Hospital and I feel very privileged to be here. I want to thank you all for coming to listen. And so you've heard that we know a lot about this disease now. We know a lot about prevalence. You've heard about the genetics, how it's triggered, what the immune mechanism is that sets it in place, how we diagnose it, what the diagnostic criteria are. And yet, there's room for more. What we need is a uniform approach to monitoring. You see, we get to the point where we have the disease diagnosed, identified, and yet our group at Children's, and I give them the credit, it wasn't me, sat down and said, you know, there's a gap here. When these people go to the doctor, how uniform is that approach? How certain are they of what they're doing? And I am very proud of this celiac group who said, you know, it's time for a best practices conference of experts. They funded this activity. And it's not a minor undertaking, as I'm going to explain to you. And directed by Dr. Snyder, they assembled a group to have a meeting that gives us the criteria to guide us as we manage a child from one visit to the next. Now look, this is not rocket science in the sense that we're looking at molecules, but it's the everyday reality of providing great care. Dr. Snyder gathered together this list of experts you see here, and notice the heading under which he published the work, Expert Recommendations for the Management of Celiac Disease. And it's evidence-informed. It isn't just the opinion of these guys. They go through a very serious process to come up with what might sound like simple recommendations. What I'm going to do today then is take you through that process in a little bit of detail so that you can appreciate just what goes into this sort of decision making. And then I want to go a little more rapidly through some of the recommendations that we have before us. The method used is called the grade method. You see that guy with the headache over there? The reason is that there is a vast amount of literature that's poured out all the time relevant to celiac disease. How do you choose from that what you want to listen to, and how do you reject the rest? I could add another challenge over there. It's cost-benefit ratio. We've got vast amounts of testing we can do. When do we apply it? When do we hold it back? How do we as physicians deal with that responsibly and with your insurance company and your ultimate cost if we just throw the book at you every time you arrive for a visit? And yet, we need to know enough to assure you that when you leave, you're getting the best of care. So the medical profession sat down. Traditional medicine sometimes gets a lot of hard knocks, which makes me sad. But they sat down and have developed an approach, this grade method, which I want to explain to you. The way it works is you identify a practice and you say, gee, is this a good thing to do? And then you decide, yes or no. But how do you decide? And if you look over here, you grade the evidence. You look at the literature paper by paper that is of relevant papers, and you decide, is this high quality, moderate quality, low quality, very poor quality? At the one end of the spectrum, we've got controlled trials. At the other end, we've got sort of verbal reports. We weigh them up, and we grade every paper. Then we look at them to say, what's the risk-benefit ratio? What's the strength of this paper? Does it give us more good than bad? Yes, we could do it, but is it worthwhile? And you put those together, and then you have an anonymous vote by a group of experts and decide, yes, this is a good idea. And that's the process that Dr. Snyder put these experts through in the following way. And I'll give you an example. So here is method for reaching consensus regarding a best practice. You saw the best practice statement. We're going to decide yes or no. At the first visit, will they do it? At the second visit, will they do it? What's the grade of evidence to support it? Is it worthwhile? Risk-benefit ratio. So we'll take one. Should we do routine initial quantitative IgA and IgA anti-tissue transglutaminase values? You've all heard from Iva and you've experienced this. This is that screening test. Should we do it? Well, the grade of evidence is high. There are any number now of controlled and well-accepted trials that say this is a great thing to do. Is the risk-benefit ratio worthwhile? Absolutely. Yes, it costs something, but we really need that answer. And so when you vote, not surprisingly, you're going to get a yes. First time around. Not surprisingly, you don't need to repeat it necessarily to make the diagnosis. We will repeat it to monitor the progression of the disease. So that's the process that underlies the recommendations that were reached. Dr. Snyder drew together experts in 6 areas from 6 major centers in Canada and the United States. And they looked at bone disease, endocrine problems, hematologic issues, liver disease, nutritional problems, and tests to make the diagnosis. They reviewed over 600 papers, original science. They selected 172 of them as worthwhile, and then put them through this process that we've just described, and went through the anonymous voting. So let's look at the consensus on best practice for bone health. Here's the challenge. There are a lot of things that could be interpreted as to represent bone disease in patients. Symptoms like bone pain, muscle spasm, even a thing called tetany, where your calcium levels are too low and you go into strain spasms. There could be growth failure, fractures with minimal trauma. And we've recently had 2 cases just like that. Children who, out of the blue, have a fracture, there's nothing else going on, and you look more closely and lo and behold, they have bone disease, and lo and behold, it's due to celiac disease. Even rickets has been described, and osteoporosis. Now, these are rare at presentation unless you do bone scanning. But if you scanned everyone at the time of diagnosis, at least in studies that were done a few years ago, as many as 40% of the diagnosed celiac patients actually had decreased bone density. I suspect the number is much lower now as we're diagnosing far earlier and the disease is not advanced that far. But nonetheless, it's an issue. But here's the good news. On a gluten-free diet, that bone density, at least in young children, reverses rapidly. And by the end of a year, the great majority are approaching normality. Now, that has implications for us. You know, would we do a bone scan on everyone? It seems like a good idea. But if you're going to be on a gluten-free diet anyhow, and at the end of a year you're going to be looking great, why do it? So who do we choose to do it on is the sort of challenge that we've got to confront. And it is true, however, that most bone problems relate to bone density, so it's an important thing to take into account. Now, here's the other side of the dilemma. We can do a lot of stuff. We can do vitamin levels, we can do calcium, phosphorus, alkaline phosphatase, parathormone, etc. Many tests that look at bone health. We can x-ray, we can do these DEXA scans. And what we've got available to offer is calcium, vitamin D, exercise, a gluten-free diet. So here are the best practices that came out of the meeting. Strongly recommended was the simple stuff. It would seem like common sense, right? You should see a dietitian who tells you to take calcium and exercise and so on. But you know, in order for these common sense practices to be instituted, you need that body of evidence that says it's a must-do. And I think that's therefore a strongly recommended recommendation. Bone density, well, I think you understand now that you don't just do it gratuitously, but if you have someone following not following the gluten-free diet, despite the counseling, there you must certainly want to do the density and point out to them and also know whether it's a critical issue. Weaker recommendations are to do vitamin D at the time of diagnosis. It's a weak recommendation, but the risk-benefit ratio of doing a vitamin D at the beginning is very low. And even though you're going to go on to vitamin D, maybe you need a little more. And in some parts of the world where sunshine's not so plentiful, Ohio, you might want to take account of that. Routine screening for calcium, phosphorus, and the other blood tests. When would you want to do those? Do we just rattle them off in the beginning? No. The patient with severe malabsorption, with bone disease, one who's been diagnosed very late and has obviously got that, sure, there you're going to do it. But in the average healthy child, we know that they're going to go onto the gluten-free diet, that this is going to correct. We don't absolutely have to do that all at the outset. Bone density at 1 year of age, if it is previously abnormalities that require us to check. I've gone through the bone health in fair detail to give you a flavor of how the decision-making is made and how we try to balance it. Now, consensus for the best practice of hematological issues. The bone marrow produces blood, and the blood has a variety of elements in it. We have the red blood cells, obviously, but we also have that white blood cell population coming out of there, and these things called platelets that help us with coagulation. Interestingly enough, in some celiac disease, all of these components can be implicated, but it's anemia that is by far the commonest presentation. And if we look at anemia, it is iron deficiency, which by far is the most common denominator. And therefore, we want to look at iron closely. And iron is particularly important because you can be iron deficient even before you're anemic. Also relevant, you can have deficits from iron deficiency that don't relate to anemia. Cognitive ability even has been compromised by being iron depleted before you're anemic. So we want to know about iron, and that's going to have implications for how we design the recommendations. I want to just point at the white blood cell area, and I'm going to come back to it because there might be some compromise there too that we need to take into account. And it's very rare that you would see bruising or bleeding, and if those occurred, you would obviously look for them. But the group voted on 3 things. They said, what routine initial screening should we do? And decided that everyone should have a full blood count where they look at this red cell size, but in addition, we should look at iron right at the outset. They also suggested that in follow-up, we at least do the full blood count. But folate is an example of a vitamin that often is low at the outset of celiac disease, but it corrects very readily. And it is not that commonly involved, nor does it have those subtle effects. So we don't routinely do a folate unless we've got a child who maybe has very overt disease. Consensus on best practice for endocrine conditions. You've heard from Iva and Ed how common predispositions for autoimmune disease mean that celiac disease is accompanied by other conditions. And if you look at the organs here, and you look at the conditions that come with it, we all know that type 1 diabetes is a real concern. We also know that autoimmune thyroid disease is a real concern. And if you look at the numbers here, autoimmune thyroid disease has been found, or celiac disease has been found in 7% of children with autoimmune thyroid problems, and in 3 to 12% of children with type 1 diabetes. It's far rarer with the other autoimmune hormonal disorders. What should we do there? And societies have recommended that patients with type 1 diabetes should all be screened for celiac disease. They've also recommended that those with autoimmune thyroid disease might be screened. And what's the reverse? Should we be screening every child who has celiac disease for type 1 diabetes? Should we be screening them for autoimmune thyroid disease? It's not so clear. So let's look at what was decided. The summary was that routine counseling about the signs and symptoms of diabetes should be given from word go. Patients who have celiac disease should be aware that you could develop diabetes. And the common symptoms, the urine losses and so forth, should be looked for. You should be alert for them. But should you actually do the immune studies against the islet cells of the pancreas, which will tell you that you might be predisposed to diabetes? That's a much more difficult question, as Ed has suggested. And we're not to the point where we can recommend that and should not do it. It's expensive, and we also don't know how to do anything about it in that pre-diabetic state. Now, that's very different to the situation with thyroid disease. With thyroid disease, if we screen for it and we find that the hormone promoting the production of thyroid hormone is not around, so-called TSH, we're in a great position to treat if the situation is affected, and it's a very easy thing to do. So we have a separation. We would screen for the thyroid disorder in celiac disease, but we wouldn't intensely screen for diabetes unless it became more evident. Now, liver disease, the liver is one of the areas more commonly involved, and yet, thank goodness, mildly involved in celiac disease. We know that a great many children will have raised liver enzymes. The liver is involved in an inflammatory process. It leaks these enzymes out into the bloodstream, so we can readily screen for liver disease by looking for these enzymes right from word get-go. We know that there are a number of liver diseases that could be associated. The vast bulk of them, however, are very, very mild, and fortunately, on a gluten-free diet, we watch those enzymes return to normal. The implications of those enzymes are, it's a great screen in a sense. It's the reverse that's really important. If we have unexplained elevation of liver enzymes, we now know that one of the things we've got to look out for is celiac disease, even in a child who may not have other symptoms of that sort. But we also know that if we find it, occasionally there could be associated autoimmune hepatitis. So we take all of that into account. I had mentioned to you that the white cells come from the bone marrow, and that the white cells might also be involved in celiac disease, and somehow there's evidence of impaired immunity in some instances. And here is one that has been brought to the attention of the medical community recently. Children with untreated celiac disease, not infrequently, failed to demonstrate a reaction to their hepatitis B vaccination. And we now recommend that at the outset of the disease, at the time of diagnosis, we should screen to see that the individual has developed a reaction to hepatitis B, so that we can boost the vaccination on the diet and make sure that there is genuine protection. Now, let's turn to nutrition issues. So there's the diet. The stuff in the glass is not blood, it's prune juice, okay, which can be useful in a gluten-free diet for various reasons. Now, problems preceding diagnosis. Diet is something we have to attend to continuously, for both the fact that prior to the diagnosis, there are many dietary issues that could have arisen due to malabsorption of vitamins, nutrients, etc. But this is the one situation where the treatment becomes the problem. And insistence on continued nutritional surveillance becomes possibly as important, if not more important, after you get onto the diet. We all know that the goodies in the gluten-free diet tend to carry a lot of calories, that there's a real concern about obesity. There's been a recent report of possibly increased heart disease amongst patients on a gluten-free diet compared to controls, presumably related to some of the excesses that you might be tempted to participate in. So having a well-balanced diet is an ongoing critical issue. And therefore, not surprisingly, a strong recommendation is exposure to a qualified dietitian over time and repeatedly so that this diet can be assessed. Now, turning to some of the other elements in nutrition, should we screen everyone at the outset for things like zinc deficiency, which we know can be low with celiac disease? The answer there again is no, because once more we are going to make sure that once diagnosed, you're on a good diet, you're getting supplements at the beginning at least, and that's going to be taken care of. We don't have to go through every nutrient possibility and subject it to testing. What about multivitamins? Should they be advised? And the recommendation is that they should be given at the outset at least, and until the child is in better health, and maybe then it becomes more questionable. Finally, let's very quickly go through the recommendations on testing. I say quickly because the recommendations on testing really were not altered. The recommendations developed by the guidelines for the North American Society and the adults, the things that I have been so active in writing, are pretty well accepted. I put the slide up not because of the baseball player in the middle, but because of the people who surround him. This is the core group of our celiac program. Missing from this picture, unfortunately, is our dietitian, and Laura Hashiguchi, and I put it up here for a very good reason, and I think that history is important, and let's look at that progression. This family had a child who went for far too long and suffered far too greatly before ultimately a diagnosis was made. There is a silver lining. The silver lining is that they then came to Children's Hospital, eventually met with Dr. Snyder, and prompted the formation of this celiac group. Following that, they expanded and drew into their midst people like Vanessa. And the consequence of that is that you have an app in front of you which will provide you with endless information and my photograph. Now, the point of it is, though, to be serious. One of the things Blair said to me was, you know, what I wanted was for every doctor to listen carefully to what the mother's saying. Because far too many times, and you all have these stories of parents who have said, there's something not quite right, there's something not really in place, something needs to be done. Well, I think they have come an enormous distance in their mission. We've got this wonderful assembly here today, and then added to that a list of recommendations for the day-to-day management of these children at every pediatrician's office, not only in this area, but nationally and maybe internationally. And I think I'd like to end by giving them a round of applause and thanking them for making this possible for me and you.